Hello and welcome. My name is Chris Rowena, and I'm the lead communications analyst at HCAI Health Workforce. We're so glad you could join us today for this third in our series of Rural Health Transformation Program, or RHTP listening sessions. Today is focused on innovative care in rural health. Our aim is to hear directly from you, your needs, your challenges, and your ideas to ensure that California's planning for the RHTP reflects the realities of rural communities. Before we begin here, we'll have just a quick notes on how to help you get the most out of today's session. Number one, this platform is hosted on Zoom, and the controls are in your toolbar at the bottom of your screen. Number two, we will be using the Q&A feature for all of your comments and feedback. Please type your input at any time. It is already on. Comments will be moderated before they appear publicly. And number three, we are recording today's session. The recording will be available on our website within 5 business days. All right, so let's talk a little bit about today's purpose and why we're here. We're here to provide a high-level overview of the program's goals and structure, to share early survey findings, to show how your feedback is already informing our approach, and to listen to your thoughts, experiences, and ideas for a topic-specific deep dive. HCAI's commitment today is we're here primarily to listen, not to present. Your feedback will influence how we design this initiative, and this is the beginning of an ongoing conversation. Just a couple reminders. Please do use that Q&A feature to answer the questions or to submit your comments. And reminder that this is a listening session primarily, not a technical assistance webinar. So we're not here today to answer a lot of questions. We're here to hear from you and your responses to the questions that we have. And with that, it is my pleasure to introduce our Chief Medical Officer, Dr. Lamena Tefera, who will be presenting today.
Thanks, Chris. Good morning again, everyone. Happy to present the Rural Health Transformation proposal. We thought we'd start with an overview of the definition of rural that CMS is using, presented here on your slide, noting that 82% of California is a rural census tract. 57 of 58 counties have rural populations, that California has 279 rural health clinics, 296 federally qualified health centers, 76 rural hospitals, and that 76% of our rural census tracts are in a primary care health professional shortage area. This is all relevant as addressing the health of rural California is key to this proposal. Next slide, please. A brief program overview of the Rural Health Transformation proposal, which was authorized by HR 1, provides $50 billion over 5 years. The program describes multiple strategic goals, and submitted proposals should describe 3 or more permissible uses that are designed to improve healthcare access, quality, patient outcomes, and drive transformation of rural healthcare. The strategic goals are listed on your slide, and we'll be focusing on innovative care efforts to improve rural health today. Next slide, please. Regarding the $50 billion that have been allocated by HR 1, half of that $50 billion will be divided equally amongst the 50 states. The other half will be divided based on a competitive formula that CMS devised that has a lot of emphasis on rurality. As you can see on your slide here, once CMS decides that the disbursement of the $50 billion, each state will be allotted funds year by year over the course of 5 years. And not listed here, but important to know, is that there's year-to-year auditing by CMS to see if the program implementation is consistent with the approved proposal guidelines. Next slide, please. Related to the permissible use of funds that are described in the Rural Health Transformation Program application, there are multiple categories listed A through K on the slide. Today's conversation will be focused on item I, innovative care models, and largely on promoting evidence-based strategies to promote value-based care in rural America, again, with the greater aim of increasing access for health to our rural communities, promoting affordability for those same communities, all while maintaining, if not improving and elevating the quality that patients receive in those communities. Next slide, please. Regarding the program timeline, as many of you are aware, the Department of Healthcare Access and Information has been reaching out to stakeholders throughout the state, including a survey that was completed in mid-September. We've had ongoing webinars to discuss the program and our strategy to submit the application in a timely manner. You'll see here that the submission deadline is November 5th, and that the decision by CMS regarding awards will be by the end of the year, December 31st. I'd like to highlight here that although the submission is November 5th, we'll continue to be working on the granular components of the proposal even after the submission, and that your feedback will continue to be sought throughout that process. Next slide, please. During this period of stakeholder feedback, which is ongoing, and as example by today and the other public forums we've had over 350 stakeholders engaged, many clinician healthcare providers, nearly 60%, but also non-providers representing state entities, including counties, city and local governments, academic medical centers, philanthropic organizations, and also health plans. So we really sought out expertise and hope to learn from the experience of stakeholders across the healthcare ecosystem. Next slide, please. Focusing on the conversation today about innovative care, the goal is to listen and learn from you about how we should consider the most effective ways to transform how care is delivered in rural California. What are proactive ways that we can help shift care from a volume-based system linked to the fee-for-service model to a value-based system linked to care coordination and shared risk when feasible. Focusing on the areas that CMS highlighted, care coordination, flexible delivery models, value-based payments, and alternative payment models were all noted. We're happy for your comments and suggestions along those lines. It's important to note that the funding categories that can be considered to elevate proposals include innovative care, provider payments, appropriate care availability, and consumer tech solutions, which are described in the Rural Health Transformation Program application. Next slide, please. From our listening thus far, we've heard lots of feedback from our stakeholders, as noted on your slide. I'll mention a couple of the comments. The first, upfront funding to support hiring care team members, improving analytic capabilities, and making other investments to support success in alternative payment model programs was noted by a plurality of respondents. Reducing the administrative burden of participation in alternative payment model programs, align quality measures across programs, reduce reporting requirements, or using an alternate payment model structure similar to those offered by CMS with more lean reporting was also noted. Support with information technology, electronic health records, telehealth, e-consult, and other technical infrastructure funding was also noted. Next slide, please. When we look at the broad categories of feedback that we've received, that we've organized and laid out on this schematic here, we were pleased to find that our stakeholder community is viewing this Rural Health Transformation Program application and the priorities for the proposal that we intend to submit in a very similar lens as our policy and leadership team. Elevating primary care is foundational. Thinking about flexible care delivery is important. Promoting and elevating coordination of care. Equally thinking about ways to elevate the prevention of and chronic disease management, which is closely linked to the coordination of care. And with our finance teams, thinking about the sustainable funding strategies and the sustainable emphasizing that we're looking to initiate programmatic work that will last longer than 5 years and will continue to serve rural Californians on a long-term basis, not just for the terms of this program cycle. Next slide, please. As we've said, we want to hear from you and receive your feedback. Are there specific care models to integrate physical, behavioral, and social health care that we should consider? We're opening up the Q&A shortly, but this is one of the questions that we'd be curious to learn from you. Other questions are related to the benefits of mobile clinics and telehealth. I think we can advance the slide to show the next question. The addition of mobile clinics and telehealth, what are ways we can bring care to homes and schools, care to the communities where our patients live? Next question, please. Types of alternative payment models that are most feasible in rural settings, whether it's shared savings, a population-based approach, a hybrid payment model. What are the key components of models needed to be successful in rural areas? And the final question from us is to understand the unique barriers or challenges to implementing alternate payment models in rural settings that we should be cognizant of as we try to design a thoughtful proposal. So all these questions are those we pose to our stakeholders. And I'll pass it back to Chris to continue here.
All right, thank you, Dr. Tefera. we're going to move into the listening portion of our session today, which really is the heart of the conversation. Again, to participate, please click on the Q&A button in the toolbar and type your input to our questions or any general comments or questions that you might have as well. Remember, again, this is a listening session. Our goal is to gather your input. Some of the details of the program are still definitely in development, so we may not have all of the information yet. And so these four questions that we have, we would love your input. I see things starting to flow in already, and we really appreciate your participation with us today. While we wait for some more submissions to come in, one of the first questions that we had, Dr. Tefera, was is HCAI going to apply for each category? And we have a reply there, but I think it's worth speaking to this while we wait for more questions and answers to come in.
Thanks, Chris. So the proposal asks that we include proposals for a minimum of 3 categories. So we're trying to prioritize which of the categories to elevate for our proposal submission. So it's unlikely that we'll include something for all of the categories, but as many of the stakeholders know, because there's so much integration and crossover in healthcare, that whichever category we choose, there will certainly be elements of the other listed funding options incorporated. Thank you, Chris.
Absolutely, thank you. And while we're waiting for some more feedback to come in, is there anything you can speak to maybe help stir some comments on any of these 4 questions? Let's take the first one, specific care models. Is there anything that you might add to that to help people think about, oh, this is what HCAI is looking for?
Sure. Actually, I see a question that has come up. The Certified Community Behavioral Health Clinic model, or CCBHC model of care, has been successful to serve communities, increase timely access to care, improve care coordination with service providers, reduce psychiatric hospitalizations, and risk to suicide and overdose. That was more of a statement than a question. Yes, we're familiar with this model, and at a higher level, not only does the Rural Health Transformation Program application call out community health workers and navigators, but really notes that care coordination is critical to a successful transformation of rural health. So we're aware of this and anticipate that will be incorporated in our proposal submission. Just looking at other questions.
Right. But anything more that you have to say to spur in any thoughts on any of the other questions that we're asking today?
So yeah, some of the questions are a bit long, so I'm trying to read questions for participants that I can get through more quickly. There's a comment and question about mobile clinics in rural California and the flexibility of models and payments to sustain the use of mobile clinics. In response to that comment and question, I'd like to highlight that it's important to think about the overall strategy of a component of the proposal. So at a high level, we're all looking to improve access, quality, and drive affordability. In a strategy that we choose, if it makes sense to use mobile clinics to reach certain communities because geographic barriers are so challenging that that's the most efficient way to care for those communities. That's absolutely something that would be a reasonable use and should be elevated. So as opposed to focusing on the the intervention, in this case being mobile vehicle, I think what we're trying to think about is what is our larger goal for serving a particular community, and if that goal requires tools like a mobile health clinic, then that's certainly would be a reasonable use of funds to care for that community.
All right, thank you. And let's see here. A couple other questions that it looks like we've gotten. Let's find where we're at here. Uh, um, the question from Jonathan here. I'm a member of the End the Epidemics, a statewide coalition advocating for funding and policies to address the intertwined epidemics of HIV, other STIs, and viral hepatitis and drug overdose. These epidemics already heavily burden rural areas in California, and rural areas lack adequate services to respond to what we call the syndemic of overdose, hepatitis, STI, and HIV. The impact of HR1 on Medicaid will worsen these service deserts and cause more infectious disease transmissions and overdose deaths. That's why it's imperative that HCAI include in its application to CMS specific proposals to address the syndemic. Addressing the syndemic aligns with the number of CMS's goals for the Rural Health Transformation Project, such as promoting evidence-based interventions to improve prevention of chronic disease management. Anything you'd like to speak to that, Dr. Tefera?
I'd like to say it's a thoughtful comment. I think it's important to note that the impacts of HR1 in other parts of the healthcare ecosystem are an order of magnitude, if not greater, than the funding that is available through the Rural Health Transformation Program application. There are also clear guardrails in the application about use of funds. And I think we're trying to be as thoughtful as possible about what we can do to increase access to primary care services, including behavioral health services. Our thoughts on that are leaning towards the elevation of telebehavioral health and other telehealth services to promote primary care and access for those same populations that are described in the question. But it is a very difficult position that we are placed in, facing the cuts from HR1 to specifically the Medicaid program writ large, and the intervention and the help that can be provided by our proposals in response to the Rural Health Transformation Program are limited by the amount of funding, which is roughly $100 to $200 million per year. I'd like to emphasize for participants on the call today that we don't know yet how much funding we will get. As noted in one of the earlier slides, the decision from CMS will come by the end of the year. Once we know the amount of funding that California will receive, then we'll have to take another review of our submission and think through what are the priorities in the submission, and what can be achieved successfully based on the level of funding we receive. All of those will be difficult, tough evaluations and policy decisions, but again, touching on the complexity of the environment that we're working in. But thank you for the thoughtful question.
Wow. And Jonathan, we see some of your suggested proposals as well, and our team is taking note of that. We really appreciate your input today. The next comment that
Actually,
we have.
Chris, I see one question here I'd like to address. There's a commenter that notes the relationship between CalAIM programs from our state's Department of Healthcare Services, Medi-Cal, for community support services and enhanced care management, and the Rural Health Transformation Program proposal. I'd like to share that as we do with all work of this magnitude, that we're collaborating not only with the Department of Healthcare Services, who operates Medi-Cal and the CalAIM program, we're also collaborating with our sister agencies and departments, including the California Department of Public Health, in making sure that we're hearing feedback. Again, we are not short on ideas, and we're definitely aware of all the different places that can benefit from an investment and elevating care in rural California. The balance for us is finding or writing or submitting a proposal that is going to touch on the areas of interest highlighted by CMS, and also being cognizant that we're not yet aware of how much funding we have, and being prepared to direct the funding that we eventually receive in the ways that we think will be most effective. But we're very much collaborating with our sister agencies and hope to incorporate, elevate ongoing programs as much as we can.
All right, thank you for that, Dr. Tefera. The next comment we have is from Joseph. And Joseph says, we would love to help scale hybrid payment for primary care across the state. At Blue Shield of California, only 10% of primary care practices participating in our hybrid payment model are located in a rural area. We feel there's ample opportunity to help practices prepare for participation, investments in IT infrastructure, technical assistance, and more. The California Advanced Primary Care Initiative provides some of this support. Have you thought about engaging CAPC leaders on the issue?
Thanks for the comment. So we have lots of links with Blue Shield of California, and also touch bases with California Advanced Primary Care Initiative. I think that is certainly in line with the intent of this component of the program application, and we'll continue to have those conversations with leadership from the stakeholders that are mentioned, and also welcome feedback from other stakeholders who have thoughts on elevating and promoting primary care. As many stakeholders on this call know, the Department of Healthcare Access and Information is committed to elevating primary care writ large, separate from the Rural Health Transformation program, and we see this proposal opportunity as very much in line with our mission and our work, and look forward to make it as robust as possible. The work in primary care as robust as possible for the proposal.
All right, thank you. Next comment is from Shah Khan. The Medicare's new Advanced Primary Care Management, or APCM, seems to a care model that would be very successful in rural settings. It incentivizes, looks like there's a missing comment there. Is there any plan for implementing this hybrid payment model into HCAI's application?
So I think it's important to note that at this stage of the application, we're focusing on submitting proposals and concepts for consideration by CMS. The particular details and more granular components will be filled in afterwards, and CMS in its public communications, including webinars to the states in how to proceed with their application, has signaled that they will continue to allow refinement and improvement of the proposal concepts. What this first part of the submission is really noting which areas of focus will each state take in responding to the Rural Health Transformation Program application. So the mentioned model, in addition to all other existing models, will be considered. Obviously, there will be a focus on trying to find out find which payer type is most sensible for the rural community. And it's important to note that a model type that might work in one part of rural California in the north, for example, may not be the same type that would be effective in the south or in the Central Valley. So we're trying to have enough flexibility and agility to have design options that will serve the communities and their needs.
Great, thank you. For an anonymous comment here, general comment, shared savings has proven to be very successful in rural communities, but to make it work, it will require robust pop health tools as well as practice coaching support on things like care gap, closure, and risk stratification.
Yeah, again, I think you mentioned that's a comment. That's a thoughtful comment, and I agree that those have to be carefully considered. I'll use that comment to pivot to a question I see here. You mentioned that the Rural Health Transformation Program encourages public-private partnerships to deliver outcomes and value. Would those partnerships be at a state level, facility level, or both? That's a good question. The short answer is that has not been fully determined yet. I think eventually, whatever funds are administered by CMS, HCAI will be the Department of Healthcare Access and Information will be the recipient of those funds and will be involved in the management and disbursement. The relationships, the future models that we're talking about, once we flesh out those details more, I think we'll then be able to see what those linkages will be. I think it's reasonable to assume they'll be formal, they'll be contracted. It's not necessary that the state is involved per se, but it might make sense that a county is involved or other city entity, depending on what's happening in the local circumstance. So there's a lot of uncertainty to how this will be programmatically implemented, but it's an important question and something that we think we'll be able to know more about a bit more downstream. But thank you for the question.
All right, thank you. Renee says sustainable funds to support FQHC, RHC, and other primary care settings to integrate SUD services, care coordination, address social drivers of health, or SDOH, that address the whole person. Mobile health is an innovative way to reach rural and frontier communities that experience social isolation, lack of community resources, lack of access due to transportation issues.
Again, I think that's an important comment. We noted before that federally qualified healthcare centers. We have nearly 300 in California. We're grateful for the service they provide communities. They are the backbone of care, primary care, in California, and serve so many communities. I think the proposal submission will certainly want to find ways to collaborate and be inclusive of federally qualified healthcare centers as much as possible. And as far as leveraging innovative means to improve the care for rural Californians in those communities, means to improve specialty access to larger centers for referral, means to decrease referral times for patients who live in those communities. Also means to receive care in that community, because instead of having the patient commute to a larger center, if the specialist can liaise with the local federally qualified healthcare clinician and provide the important advice the patient needs, uh, elevating care at the site of care in the community close to home is really important, and patients have long said it's their preference to receive care in the community. So we're very much focused on enhancing, augmenting the work of federally qualified healthcare centers, which already do so much for California, and want to do everything to help them continue to improve care quality for their communities, and also improve the experience for the clinicians who work there, trying to minimize the administrative burden and other challenges they might experience in trying to care for their populations.
Dr. Tavera. Along those lines, Renee also asks, have there been any discussions with the California Primary Care Association and possibly a collaboration to identify their strategies in support of primary care providers?
To reflect back, I hope folks on the call can imagine we've had a lot of stakeholder engagement. So I have to double check if we've met with them during this period, but certainly in our primary care strategy work we have with HCAI writ large. But I think there should be no doubt from the stakeholder community that whether it's for the Rural Health Transformation Program application submission or our work at HCAI writ large, elevating, promoting primary care, and noting that a functional advanced primary care system is foundational to improving health outcomes for patients, which is our goal, and certainly a shared goal with stakeholders on this call, and also decreases overall healthcare costs, and that makes access to care and affordability easier for patients as consumers who have to pay for these services. So we're absolutely committed to making sure that primary care has a prominent role in the proposal submission.
Thank you. Another comment and question along with it. Leveraging community pharmacies more fully will help expand access to healthcare, especially in rural communities. In order to do so, really need to implement payment models that support pharmacies for the care they deliver and remove existing administrative and scope burdens that limit their reach within communities. Have you considered engaging with pharmacy leaders regarding this matter?
Thanks for the question, and thanks for calling out the important role of pharmacists in our healthcare ecosystem. I think the value and critical help for communities of pharmacists was really shown during the heightened years of the COVID epidemic, when patients and Californians really saw how much care can be received at a pharmacy. I think it's really important to elevate the ability of pharmacists to practice in their full scope of skills. The Rural Health Transformation Program application notes that upskilling and expanding the roles for different clinician types in rural California is desirable. That likely will involve regulatory changes or seeking regulatory changes to expand the role of pharmacists where there might be limits on license. But that's also true for other clinical care types, whether it's dental assistants supporting dentists in rural California, or nursing who might need changes to their scope of practice to elevate the care that's provided in rural California. So we're certainly being thoughtful and thinking about ways to elevate all clinician types who support Californians to make sure they're working to their as much as possible to their full scope. And that's definitely being evaluated, and there'll be some component of that included in the proposal submission. So thanks for bringing that question up and elevating the importance of benefiting from all clinician types supporting rural California.
All right, thank you. Stephen Chen also has a comment and a question. Let's see here. Medication therapy optimization is key to controlling almost all chronic diseases. Comprehensive medication management, or CMM, provided by pharmacists is an evidence-based, team-based care strategy that has proven to be effective when offered by FQHCs, but is uncommon since pharmacists are not federally recognized as billable providers. In California, policy and legislation provides payment pathways to offer sustainable CMM through community pharmacies. Could this proposal include support for training, coordination, and CQI to help pharmacies provide high-impact CMM in partnership with FQHCs?
So yeah, thanks for the comment. I think this touches back to the last question about elevating our clinicians to work to their full scope. Besides state-based regulatory changes, the question is noting that there would be federal changes required. That's outside, our ability as a state, but that's certainly something that can be elevated to CMS and Medicare. But I think the general principle here is that there's a benefit to rural healthcare and likely all healthcare throughout the state if we increase the ability of pharmacists in this case to collaborate with federally qualified healthcare centers by having an expanded scope of care, and also touching on that it's important that financing keeps up with all the work that's done by our clinicians and our clinics, because those clinicians in their practice sites and those clinics need a sustainable finance model to maintain their work for the communities that they serve.
Thank you for that. I've got an anonymous question here. Has there been any discussion about an ER primary care model, as rural ERs can have lower volumes and have availability to see additional patients and are open 24/7?
So I did not mention that besides being the chief medical officer at HCAI, Healthcare Access Information, I'm also a practicing emergency physician. I think emergency physicians will generally say that emergency departments have been performing primary care for decades already. But a big part of the reason they've been performing primary care is the lack of access and affordability, whether folks are uninsured, underinsured or have made a health plan selection that doesn't offer them a resource to go to in a timely manner that's responsive to their work schedule, their family management schedule, whether it's children or caring for a loved one in the home. The emergency department, by nature of its location, is one of the most expensive sites of care because of the facility fees related to the site of care and the potentially intensive treatments that occur there. What's been discussed a lot is making sure that we have good collaborative communication when patients have emergency department visits, that there are warm referrals or direct referrals to outpatient care that is in a timely manner. Again, timeliness is a challenge. Timeliness depends on your location, your health plan type, and for many folks, even with a health plan that offers a provider that could see them in a reasonable amount of time, if their copay is a barrier, then in their experience, it's just as if there was nobody to see, and that's a real problem. And again, going back to our mission at HCAI to promote high quality care, promote access across our 58 counties, and elevate affordability. These affordability issues are real, and as noted in a response to another question about the impacts of HR1 across the healthcare ecosystem, we anticipate there'll be more Californians without health insurance as a consequence of HR1. So that will be there'll be more Californians making more difficult choices because of affordability and cost issues. So while the emergency department and emergency physicians already do a lot of primary care, as a site of care, it's not ideal because of the costs, but making sure that they're closely linked to primary care and local clinics is really important, and making sure that patients have an affordable option to be linked to outpatient care is incredibly important.
Thank you, Dr. Tafera, for that thoughtful response. Wonderful participation today. We really appreciate everything that everyone is bringing up. We've got about 10 more minutes left. We're going to keep going. Brian says telehealth is a useful tool to bringing providers to areas, reducing the burden of transportation on patients, etc. Clinics often do not know where to begin. Can this grant help create telehealth infrastructure in clinics? And also mentions about traveling mobile clinics as well in that thought process.
It's a thoughtful question, and I think touches on two things. One is infrastructure and allowable use of funds to purchase the equipment needed to stand up telehealth. And a second component of that is once you have the equipment, or alternatively, if you already have the equipment but don't know how to maximize its use, is there opportunity for technical assistance to help the clinic or the physician's office make sure they know how to use the telehealth equipment and modality to its most in the most effective manner to the benefit of the patient they're caring for, and as described in the use of funds in the Rural Health Transformation Program proposal, we do think that this type of technical assistance and support is a usable fund, and we'll be looking for ways to support clinics in elevating their use of telehealth, so they're bringing the maximal benefit of that technology to the patients they're serving in the community.
All right, thank you. Renee asks, Partnership Health Plan has a regional model as an MCP. Will the application include support for the regional collaboration?
So again, we've had several of these stakeholder calls now. On the first one, I think we talked more about regional collaboration, but collaboration with rural communities, collaboration with the clinics in those communities, the hospitals in those communities, increasing the connectedness between the hospitals and those clinics strategically makes sense. I think it's important to note here, and I appreciate the reference to Partnership Health Plan, that although there is a large population of patients in rural California who depend on the Medi-Cal program for their care, there are also many rural Californians who depend on commercial insurance for their care. So working together with commercial plans in the strategy for this proposal is important, and we have been in contact with multiple health plans, and will continue to be in contact with multiple health plans to learn from their expertise of the regions where they have provider contracts. Learn also from them about the challenges they've experienced historically in certain rural areas, and how we can collaborate to overcome those challenges to increase services to those areas, and not just by commercial care, mind you, but also collaborating with Medicaid, so that whether it's through a commercial route or through Medicaid, rural Californians will receive the care they need in a timely manner.
All right, thank you. Okay, we've got just a few minutes left. We're going to take one or two more. And let's see. One of the comments from Renee as well was that the transition to value-based care models are challenging for rural communities due to lower patient volumes, unless there are strategies that consider the cost of care delivery.
To the comment, I would say that is a true statement. I'll also add that transitions to value-based care models, even in sites of care that have higher volume, whether it's urban or suburban, is also challenging. So transitions to value-based care and risk-based arrangements are complicated and are not easy. So I generally agree with that description. I think that's a fair description.
Thank you. See, one of the questions that was already answered in the through text, but I think it's worth calling out. It says the comment survey is closed. How do we share ideas for evaluating partnership opportunities at the state level? And the response was, please send your comments and questions to the California State Office of Rural Health at calsor@hci.ca.gov. And I think that's really important for us to call out as we go along. In particular today, if you come to the end of this webinar and you think, wait a minute, after the fact, I thought of something that I should have said, please just email us over the next few days. Remember, we do have short timelines, but we still do want to hear your thoughts and your questions, and in particular, your ideas and partnership opportunities, all of those as well. So, all right. Well, we are just about out of time today, and really appreciate everybody's participation. Dr. Teferi, do you have any closing thoughts or comments before we move to the end today?
No, thank you for the questions and the comments. It's clear that our stakeholder community appreciates the complexity of the issues and the complexity of devising a proposal to elevate rural Californians' care. And we certainly appreciate that, and we look forward to the collaboration and the final submission of the proposal. So thank you, everybody, from my end. Thank you.
All right. Well, thank you so much, Dr. Tefera, and thank you everyone for your thoughtful participation today. We want you to know that we have captured all of your questions, all of your comments today, even if it wasn't answered live, even if you didn't see it pop up on the screen. We have captured everything, and we really value your contributions to this process. Again, if you think of anything additional that you would like us to know, please email us at calsor@hci.ca.gov, and we'll have that on the screen here in a minute. Your feedback is a really essential part of shaping California's plan for the Rural Health Transformation Program. But before we go today, we would encourage you to just view a few of our resources at large for HCAI. You can always go to our website and visit us on social media. We have all of our channels active and running, and we would love for you to participate with us on those. And there we go. Please follow us, and please comment with all of the great work that you're doing. You can tag us and let us know of the amazing things, amazing ways that you're contributing to making California a healthier state. And then on that last slide there, we would love for you to subscribe to our monthly workforce newsletter. You can go to this address or go to our website and hit subscribe. Just make sure that you click on any of the options listed under Health Workforce, and you will be subscribed to that monthly newsletter to stay up to date on all of HCAI's Health Workforce offerings. And again, you can contact us with any additional information that you would like to provide at calsor@hci.ca.gov. Please share this opportunity with others in your network. We are not done with these sessions. We have session 4 today at 2 p.m. and session 5 at 10 a.m. tomorrow. So please share this with those that are not here that you think should be. This does conclude session 3 on innovative care for the RHTP listening sessions. Thank you again for joining us, and we look forward to continuing the conversation in the sessions ahead. Have a wonderful day.